Ready? Okay, hi, hello everyone. Welcome to the UCLA Center for Health Policy Research and to our 2015 seminar series. My name is Gwen Driscoll. I am the Director of Communications here, and it is my pleasure to welcome you once again and to this discussion of a topic that is of ever-increasing importance to our aging society, clinical preventive services. Within the next 20 years, an estimated 76 million Americans born between 1946 and 1964 will enter their senior years. In California, the elderly population will double to more than 9 million by 2035, and Latinos will comprise the largest group of older adults by mid-century. If preventive care solutions are not offered to seniors now, our elders and our society may bear a hefty burden later. Today's seminar will present early findings from a new project to increase the use of clinical preventive services, such as flu shots and mammograms, among older residents of South Los Angeles. This is an innovative, interdisciplinary project that combines teams of UCLA researchers, community groups, and health centers, the LA Department of Public Health, local aging resources, women's groups, and more. Just before we begin, however, I do just want to let everyone know to save the date for our next seminar, which is going to be on October 28th. On that day, the center's director, Dr. Gerald Kaminsky, will speak about the very controversial issue of so-called narrow networks. Although the Affordable Care Act has created a greater degree of standardization of health insurance plans than has ever existed in the individual health insurance market, one of the most significant remaining features that can vary considerably is the number of doctors and hospitals contracting with each health plan. And I'm sure many of you, when you've signed up for health insurance, have experienced this, that you can get some doctors and not others. This has led to some concern that access to doctors and hospitals might be restricted and even that patients' health might be compromised. So please join us on October 28th as Dr. Kaminsky will present an overview of this issue and possibly explode some myths about the impacts of narrow networks. As for today's seminar, we will be recording it as usual. It will be placed on our website at the address you see at the top. In terms of the Center's ongoing health policy seminar series, you can find links to all our past and announcements about upcoming seminars on our website, or by subscribing to our popular monthly e-newsletter, Health Policy News. We have more than 13,000, nearly 14,000 now subscribers, so please join if you are interested. Please also note that we have a brief question and answer period at the end of today's seminar that I will moderate. And for the in-person participants, I just want to encourage you to take one of our nifty pull-out pens with instructions on how to use AskCHIS, our handy and free online health statistics tool. Okay, I am now happy to introduce the co-presenters of today's seminar, Drs. Kathryn Kietzman and O. Kenrik Duru. Kathryn is a researcher here at the UCLA Center for Health Policy Research and a specialist on the issues of clinical preventive services, aging and long-term care policy, chronic care coordination, as well as major healthcare delivery innovations, such as the Cal MediConnect program. She is currently the evaluation director for the Healthy Aging Partnerships and Prevention Initiative, which is what we're going to be talking about today, and what we also call HAPPY. And she's directed other large-scale and complex projects here at the Center on Long-Term Care and Clinical Preventive Services. Kenrik is an associate professor in residence and internal medicine physician at the David Geffen School of Medicine at UCLA. He has experience in collaborative research with community organizations, including leading a randomized controlled trial of a pilot faith-based physical activity intervention for older African American women in South Los Angeles churches. His broad areas of research interest include enhancing physical activity amongst minority seniors and designing interventions to reduce disparities in medication adherence and clinical outcomes among patients with diabetes. Along with the center's associate director, Dr. Stephen Wallace, and Dr. Janet Frank, a center faculty associate, he is a co-investigator on the HAPPY project. So please welcome Drs. Kathryn Kietzman and O. Kenrik Duru.
Okay, good afternoon, everyone. Thanks for the chance to come and speak about something that Kathryn and I are very excited about, as well as our other team members who we represent. We have a powerhouse team, which I'll describe, from multiple different disciplines, all working together on this important project. Oh, okay. Sorry, I should have done this earlier.
It's over here. See that arrow right there? And then just click it over.
Okay, thank you. So I'll begin by acknowledging our funders. We are funded through the Department of Health and Human Services, the Office of the Assistant Secretary for Health, the National Prevention Partnership Awards Program, and we also receive funding from our local UCLA Clinical and Translational Science Institute, CTSI. So overall, what is HAPPY? It's a community-engaged research project, collaboratively led by multiple individuals from different organizations. We have leadership from the Los Angeles Department of Public Health, from the Southside Coalition of Community Health Centers, which I'll be describing in more detail. It's the umbrella network that oversees or coordinates, in some ways, the clinics that we're working directly with. We have representation from the LA City and County Departments of Aging, as well as local community-based organizations, and a multidisciplinary group of UCLA investigators. We fit everyone, I think, on this slide with 2 rows and fairly small fonts. So people, I think, know Dr. Stephen Wallace, Kathryn and I, Janet Frank, Rosanna Leos is in the room. On the right side, Nina Vaccaro and June Levine from the Southside Coalition. We have folks from, as I mentioned, the organizations on the previous slide working with us on this. So now we'll get to the background. I think people here probably know that clinical preventive services, which we'll call CPS going forward, reduce rates of premature death and disability in older adults and support healthy aging. Unfortunately, the use of evidence-based clinical preventive services is below Healthy People 2020 recommended levels, especially among racial and ethnic minority elderly. It's a very high priority group. And community-based programs, for example, at churches or senior centers or YMCAs and many other different CBOs, have been proven to increase CPS delivery to this group. And I believe for those in the room, that's the handout that is in front of you, which if you can read at a later point, not right now, but at a later point, if you look in, there's multiple examples of very effective programs that have been through community organizations. So we're really thinking outside the clinic walls into the larger community sense in South LA for this project. So overall, the HAPPY goals, first one, or really the main one, is to try and increase core CPS use by adults aged 50 years and over in South Los Angeles. So there's certainly many different types of preventive services that we believe are effective and useful, but the mandate for this project and the ones we're focusing on are the 6 on the screen. So breast cancer screening, which is mammography, cervical cancer screening, right, which is pap smears, colorectal cancer screening, influenza vaccinations, pneumococcal vaccinations, which are intended to prevent pneumonia due to a particular type of bacteria, and then cholesterol screening or lipid screening. And our hope then, with increasing rates of use of these CPS services, is to reduce CPS disparities in the African American and Latino populations, which really are 95+% of the South LA region in which we're working. So this is the conceptual or underlying model driving what we're doing. People may have heard of this. It's the sickness prevention achieved through regional collaboration or SPARK model. So you can see there's 5 circles on here. There are 4 that are in green on the right side. And we're all working together kind of in a unit. So you'll see community health centers are there. They actually provide the services, follow up with patients with abnormal results, for example, abnormal mammograms, abnormal colon cancer screening. Network with LA Department of Health, which is providing immunizations. There's LA Departments of Aging, which are going to connect us to each other and to the community. And then you'll see there's UCLA there, providing kind of technical assistance, capacity building, etc. And really we're all working together to then engage the community organizations who are really key to everything that we're doing. So that would be the large blue circle on the left. So this is all running through community organizations. Unlike maybe the typical clinical model as a doctor I'm used to, this is really a community-based model. That's the focus of how we plan to achieve the goals. So these may include churches or senior centers or barber shops, beauty shops, fraternities, sororities, YMCA, anything really in the community that serves older adults as their clientele. And we have a community advisory council, and then they actually will feed back to us. There should be a continuous feedback loop with iterative process over the period of the study to work with these organizations to help them to help the patients to improve CPS. And I mentioned this earlier, but really one of our key partners in terms of the community health centers is the Southside Coalition, which I'll show on a map for those of you who like maps shortly, but it's a nonprofit organization established to sustain, coordinate, and improve healthcare access and delivery to the impoverished and vulnerable community members of South Los Angeles. So it coordinates the efforts of 8 federally qualified health centers, FQHCs, that have 40 actual brick and mortar service locations serving South LA. So many of them, or most of them, have at least 3 or 4 sites. So they're really a major presence. For those of you who know LA, this is really, it's not the county DHS clinics, but it's other clinics that serve the safety net population in the South LA region. And you know, they impact a lot of folks. So 205,000 plus unique lives served annually. Of course, that's all ages from the smallest child to the oldest adult. So this is the map I mentioned. So here are the 40 on-the-ground sites. So the area in blue is SPA 6, which people probably here know. It's kind of the Service Planning Area 6. We realized early on that people don't really pay attention to SPA 6 if you're a patient. Right? This block is SPA 6, the other block is not SPA 6. Does it make a difference? So these organizations really work in the areas that are in red, which are adjacent and really the same community. So we decided we can't be constrained by boundaries of service planning areas, and we're really looking at the whole neighborhood structure in South LA and adjacent areas. And we have a pretty good geographic spread from up close to the 10 to downtown towards Compton and Linwood, on the western side towards Inglewood, and actually some towards Hawthorne and Lenox. So really this is the key of what we're doing, and point number 1 is highlighted in yellow because Kathryn will be going into more detail. We're doing a comprehensive assessment of the current capacity to deliver CPS in these health centers, and she'll go through what we found to date. And I'll actually at this point give an overview of what's to come. We may hopefully get a chance to come back and present more results and findings from activities 2, 3, and 4 as we progress. So number 2 is really to provide training for community health centers in new strategies to improve CPS delivery. I think often clinics are, in terms of even clinical strategies, they're doing what they've always done and not always up to date with the latest evidence-based approaches to try to engage patients and increase levels of CPS. So we'll explain to them and train them in terms of the options they have. And then number 3, we'll also train the community-based organizations, right? You can imagine many of these churches and Ys and barbershops may not necessarily, they may want to increase CPS, but not really understand what CPS is, what is needed, what are effective ways they might join this effort to do that. So we have a set of community trainings for all interested community organizations, and I always give this pitch. If there's anyone here who has contacts with an organization in South LA that serves minority elders, please talk to us. We have wonderful trainings coming, and there's small grants, which is number 4, that we can potentially fund them to become involved. So we're really trying to get any organization that has an interest in this is welcome to come work with us. So number 4 then is to fund small grants. So we have money set aside ranging from 10 to 20,000. So it is small grants, as the word describes. But it's really hoping to either add to existing efforts or spark new small efforts. You have to start small, but to these organizations to work collaboratively with the center to get patients in, get them to get the screening they need, patients that may not be reached otherwise, which is really a big part of the problem, right, in these organizations, in this community. So I think these are really the 4 steps. I'll go through 2, 3, and 4 now in a little more detail, and then I'll give the floor to Kathryn to continue with more results from number 1. So in terms of the community health center training, we're really going to do 3 main things. We're going to describe the national preventive health recommendations for CPS for adults 50 and over, and then outline the clinical best practices and systems to support delivery of CPS to this population. So things within the clinic they can do. For example, there's good evidence that if you have standing orders i.e. everybody gets a flu shot unless they opt out. That raises rates, right, of flu shots. There's other things like that that have been shown to improve CPS delivery that may not be universally applied. So these are the kind of things we'll introduce to the clinics to get them to at least be aware of them. And then finally, to contextualize the clinical delivery of CPS to include community partners and resources. So we asked them, and I'll briefly steal a little bit of Kathryn's thunder, not a lot, but we asked them, what do you think of as partnerships? What kind of community partnerships do you have? And often it was, well, we partner with the hospital, or we partner with Kaiser, or we partner with the Department of Public Health. Not so much, we partner with the senior housing center 2 blocks away. We partner with the beauty shop where many of our patients go after their appointments. We partner with the park across the street. Really community organizations are not so much in the framework of the leadership of these clinics. And this is a generalization, but in large part. So one big goal is to get them to see this is kind of to really serve the community at large, you have to work together with community organizations. And that's really the main way that we're going to try to improve CPS, and clinics take a little bit of a while to understand that, but that's part of the training that we'll be implementing. We have 2 90-minute sessions thanks to DPH. We have CME, which hopefully is a draw for the physicians and the nurses and MAs who are coming. And we're trying to personalize it or tailor it, so we're going to identify a particular CPS that each clinic wants to work on, for example, colorectal cancer screening, and then devote the time to talking about what works for that CPS, what are the barriers and facilitators in that clinic for that CPS, and have discussion about an action plan to try for that clinic to move to higher rates. And this is coming up soon. Our first trainings will be next month. So the community training I mentioned will parallel the center training. Again, education and recommended CPS for people 50 plus. And then instead of the major focus on what you can do in the clinic, we'll be talking about what can be done in the community, again, in the handout that you have. What evidence programs could serve as examples? Everything must be tailored to different organizations, but what has worked before that may, with a few tweaks, work for your YMCA or your fraternity or such. We'll introduce the community organizations to the clinic partners. I think a big part of this is like at a function, right? You got to have people mingle so they know each other so they can then work together. So we'll spend time trying to get everyone to know each other and become familiar in case they hadn't known each other before. And then this will be part of the required training for these community organizations to apply for a small grant. You have to go through the training, which is another incentive for them to participate, learn about these things, learn what can be done, meet the centers, and then be teed up to apply for a small grant to put their ideas into action. And this training will start shortly after the clinic training, so later this fall. And then finally, 2 slides, and I'll cede the microphone to Kathryn. But this is leading up to the small grants program, which is to promote CHC community organization partnerships that deliver at least 1 CPS to community members. We're hoping it'll be more than 1. They're very exciting programs that bundle 2 or more services together, but the minimum is at least to do 1. And really, as I mentioned, any CBO serving 50 plus adults in South LA is eligible. The funding I mentioned, and we hope to award the first cycle in early next year after the initial center and community trainings. And I will let Kathryn take it from here.
Great, thank you, Kenrik. That's a great overview of a project which you can see has many moving parts, and it has been a happy project, and I'm really pleased to see so many here in the room and those online. Thanks for joining to hear more about it. So I'm going to be digging down a little bit into more detail about what we've been doing to assess capacity at the community health centers that are part of this coalition. So there are 3 major parts. So our capacity assessment includes the development of a community asset map, or as we like to call it, our Happy CAM. Also, we're gathering health center utilization data to get a baseline of the CPS utilization rates at the beginning of this project. And also, we're conducting key informant interviews with clinic staff and with community members who can help move this project forward. So currently, we're also identifying a group of community stakeholders who will serve as advisors and really extend the reach of this project, because a big focus of this is really the clinic and community linkages, as Kenrik has described. So the Southside Coalition of Community Health Centers has really been the point of entry to launch this work. And so the next few slides, I just want to briefly describe who the Southside Coalition actually serves. So as Kenrik mentioned, the Southside Coalition includes 8 federally qualified health centers and they serve over 205,000 patients each year. And these health centers serve a very racially and ethnically diverse population that reflects largely the communities that they're situated in. More than 1/2 of the patients across the coalition identify as Hispanic or Latino, and about 1/5 identify as Black or African American. And so while we started this project with an understanding that the community health centers have sort of more traditionally served a younger population, children, women of reproductive age, young families, we quickly learned that there's really a significant proportion of the current patient population that is aging or older adults. Here you can see while the majority of the patient population served by these FQHCs is under the age of 45, close to 1/3 represent 45 years and older. And this proportion will only continue to grow given demographic trends. So by design, FQHCs provide health care to the most medically underserved areas and populations, and the Southside Coalition health centers are no exception. In 2014, more than 2/3 of the patients served fell under the 100% federal poverty level guidelines, while another 10% fell within the 100 to 200% federal poverty level guidelines. This slide illustrates the health center's mix of payers. So Medicare represents the largest source of over half. That's followed by what's labeled here self-pay patients, and these are really uninsured. They include people who have income that's too high to qualify for the low-income programs, but that cannot afford private insurance. But this number also includes those who qualify for low-income programs, but for a variety of reasons may choose not to enroll in them. And another important payer that's listed here is the 14% that funds those patients who are enrolled in the low-income health programs. That's the Healthy Way LA and the My Health LA programs in Los Angeles County. So Kenrik started, he did show you a beginning of this map. I'm going to bring it a little bit live to show to you, just to demonstrate how we're building out this community asset map. So bear with me for a moment while I make this swap. Okay, so here we have sort of the unbounded map, and then as Kenrik described, we started with the boundaries. The blue area is SPA 6, and then the pink areas is really how we've expanded out as we learned more about the catchment areas and the actual zip codes in which the clinic's patients reside. So one of our activities has been identifying, and let me just go ahead and plot those on the map here. Here are the 8 federally qualified health centers we're working with, and then here are the school-based clinics and other satellite locations. One of our assessment activities has been identifying local community resources that can support this effort by strengthening those health center community linkages and increasing the use of clinical preventive services through these evidence-based programs that were discussed earlier. And so community asset mapping is really important because it highlights existing resources and it can be used to inform planning and implementation strategies that really map onto the local environment. It also provides a very concrete way for our collaborators to sort of look at the lay of the land in their own communities and maybe identify community organizations that they haven't partnered with, but who they could partner with, who might be able to advance this kind of work and related health promotion work. And these maps are interactive and can be customized to display particular community assets and resources. So just to give you a little bit of a couple of more examples of what we've been mapping. So we've been looking at organizations and resources that are likely to serve a 50-plus population. So these are all color-coded to map onto the FQHCs, but here we have multi-purpose senior centers, so we've added those to the map. Here we have congregate meal and nutrition sites, so we can add those to the map. I'm going to take them off so that we don't get so crowded you can't see anything. And scroll down. We've included the YMCAs and YWCAs in the area. Public libraries are a good place where some aging and older adults are likely to congregate, and they offer informational programs in general. So certainly education about clinical preventive services could be an add-on at a public library. Quite a few. Housing is really important, of course, the housing and health link. These are color-coded. The lighter pink are specifically senior housing, and the darker, I don't know what color that really is, but it's darker color, those are public housing units. So these are all congregate housing units in the catchment area of the clinics, and these are all potential places where the clinics can work to provide services, to provide education, and the community organizations can also participate in evidence-based programs. So now that looks like a lot of bubbles on the map. Just to give you an idea of the other entities that we're mapping that I haven't shown you, we're mapping pharmacies, distinguishing between those that are commercial pharmacies and independent pharmacies. Churches, big important community entity that can get involved with these types of activities. We're also mapping food banks. And it's important to also note that in the context of doing key informant interviews, which I'm going to talk about a little bit next, we've asked the community health center providers, who are your partners and who is missing in your list of community partners. So they've asked us, for example, to map mental health service providers because some of them have noted a dearth of those in their areas. Others have asked us to note homeless shelters and homeless services. So we're trying to listen and incorporate that kind of feedback into our mapping because ultimately these maps are going to be part of the training, both within the clinics and within the community organizations. So this gives us an opportunity to customize. So let me see if I can get back to the main slide here. Okay, you're back. So the other part of our assessment, moving forward, involves documenting a baseline for the clinical preventive services utilization in 2014. And we're going to also provide these data to the health centers so that they can decide what they want to really focus on. And then we'll revisit these utilization data in 3 years to reassess and see if there are any changes in the uptake of these services. We're gathering basic patient demographic data, including age, gender, race, ethnicity, insurance status, whether the patient's a continuing patient or newly enrolled, and as available information about how they were referred to or learned about the federally qualified health center. How did it become their primary care provider? And then again, these are the 6 clinical services that we're focusing on for this initiative. And so we're getting the information about what year the patient most recently received the service so that we can note whether they're up to date or not at the beginning of this initiative. So while the gathering of these baseline data is ongoing, these data provide a snapshot of the 2014 cervical and colorectal cancer screening rates at 3 of our participating health centers. And they're presented here side by side with the Healthy People 2020 goals and with utilization rates across Los Angeles County. So the far left column shows sort of the ideal, the national goals set by Healthy People 2020 for the use of these preventive services. The next column provides a point of comparison with rates across Los Angeles County. And then the remaining 3 columns provide the rates reported in UDS, HRSA's UDS Uniform Data System for the use of these 2 clinical preventive services in 2014. And so you can see that really across the board, there is a lot of room for improvement from where these clinics are with the CPS use and where the ideal goals and even how people are faring across the larger area of Los Angeles County. The other part of the assessment I mentioned before is that we're doing these key informant interviews. To date, we've completed 30 interviews with a really broad range of personnel in the health centers, including clinicians, CEOs, CMOs, CFOs, quality improvement directors, referral coordinators, and community outreach specialists. Most of these interviews have been conducted in person. They range anywhere from 38 to 74 minutes in length so far. And then we're transcribing the interviews as summaries, and 2 different researchers on the team independently review these transcripts and identify. Our focus has really been on barriers and facilitators to improving the delivery of these clinical preventive services. Questions include questions about the organizational context and the 50-plus population in general, their current practices related to the delivery of clinical preventive services, especially as they relate to these specific CPS that we're interested in and to aging and older adults. And then finally, we ask them who they partner with in the community or collaborate with. And as Kenrik noted, that often the responses we've gotten have been about other health service providers. And really, we've been looking for, you know, are you hanging out with the people in the church? Are you going down to the pharmacy and talking about, you know, finding ways to improve use of clinical preventive services? But for many, of course, this is just not on their radar. They've got plenty to do within the walls of their community health center. And going beyond that may be a new concept for some. We also ask them how the partnerships they do have help to further their mission. Part of what we've discovered in doing these interviews, they almost become motivational interviewing in a sense, because as we're asking these questions, you can kind of see some light bulbs going off, like, oh, well, we hadn't really thought about that. Well, maybe that's a good idea. Oh, we could look at this. So it's been a very interesting process. I want to share with you some of the barriers and facilitators that we have heard from the key informant interviews. And on the positive side, of course, the health centers already routinely provide these clinical preventive services. It's what they already do. But they see that there's an opportunity to improve the delivery. One of the barriers that has been mentioned is that the guidelines for these clinical preventive services are ever changing. They're complicated, and there's no real standardized process or system to keep clinicians up to date or informed. A lot of them, it seems that they have to use their own initiative to go and find out what's up to date. It's not necessarily popping out at them in their electronic health record. It's something they have to actually go to make sure that they know what the latest guidelines are. The staff in the health centers also talk about the extra challenges involved specifically with the clinical preventive services that involve referrals out of the health center. Colorectal cancer screening is one really good example of this. It's commonly pointed out that there are multiple points along the process of colorectal cancer screening where the process breaks down and the patient may not get the recommended screening. Of course, there are differences by insurance status that also affect those outcomes. Another facilitator that we've identified in talking with the community health center staff is that the Affordable Care Act is really ensured that these preventive services are provided at no cost, with no cost sharing for patients. The ACA has also introduced the Medicare annual wellness visit, which provides yet another opportunity for assessment and delivery of preventive services. Now, if you saw in the earlier slide, the Medicare population, of course, in these clinics is really quite small. Nonetheless, they do have a bulge of the 45 to 64-year-olds who are aging into that group. So this is all very relevant information and opportunity in some sense for the health centers to get involved with. So because of their need, everybody we've talked to has really said that the health center has more capacity. They want to increase their patient population numbers. So older adults may actually be seen as an emerging market for them. On the other hand, because the health centers have traditionally served a younger population, they may also need to increase their capacity to be responsive to older patients who are much more likely to have complex and chronic health conditions. So one of our key informants, this quote I'll share with you, when we were talking about how it is to serve older patients. She said, "It's not fun medicine. Chronic disease management, it's a burnout. It's not like people get better. All they do is get stable for a while, and then they get worse." So there is a whole culture that you have to consider when you think about the mindset of people who gravitate to the health centers. Are they going there because they want to work with kids and newborns and young moms? And it's a really different type of patient to deal with when somebody's aging and they have multiple chronic conditions. The health centers are also having problems in general retaining primary care providers, and because other providers can often pay more and offer more incentives. So that's another barrier to really moving forward with increasing service to this population and increasing the delivery of the CPS we're talking about. We have learned that health centers with providers trained in geriatrics, let me make sure I'm on the right slide here. There are a few. We found that there are a few who are trained in geriatrics, and they can actually serve as champions within the health center. to advance the delivery of these clinical preventive services. However, so many of these health centers are having so much trouble just finding any kind of primary care provider, let alone those with expertise in geriatrics. So the opportunities to populate with geriatric specialists are probably a little slim at this point. There aren't very many of them to begin with. So having long-standing relationships with specialty providers was found to be a facilitator. When referral coordinators have a good relationship and know who they're referring to, they can often facilitate that process. However, the availability in general for these specialties is quite limited. And oftentimes they're not geographically close to the health center, and this presents a challenge for many patients, especially those who have limited mobility or limited transportation options. Some of the older adults are dependent on their adult children, for example. And if they could go across town in the middle of a workday, that really can pose quite a barrier. So collaborations with community organizations, some of our informants recognize that this really can benefit the centers. They provide outreach opportunities and a chance to reach sort of untapped markets. But one challenge, however, that we've discovered from talking to these folks is that these collaborations are often time limited. They're usually formed around a particular project that's funded for a limited period of time, and so when that funding wraps up, then the project often wraps up. And a part of what our goal has been with this project from the beginning is to find ways to ensure sustainability, which is part of the reason we're doing this mapping and in finding where existing community resources are that can engage, who can be committed to this as part of their mission, as part of what they want to do moving forward. Another issue that we've run into is that these centers often have the crisis of the day. There's something that's really on their front burner. And so clinical preventive service delivery, which is very good, all the clinicians will agree that this is a very important part of healthcare, but those acute issues tend to take the front burner. And so efforts to increase clinical preventive services delivery get derailed when the next requirement or something comes to change the systems. Sometimes these are seen as, I think, secondary to the most pressing problems that the centers are facing. So they're really in a reactive environment much of the time, rather than proactive and able to move forward and think long term. So we've also heard that the availability of health center or community-based staff that can help assist patients through that referral process I was describing can really help improve clinical preventive service delivery. But the availability in the centers that we've spoken with is really quite limited. There are few, if any, navigators that are dedicated to each clinic, and often they're focused on a specific health issue, which may or may not include preventive services. Also, while we learned that navigation sort of activities are often informally assumed by referral coordinators and case managers, these efforts seem to really rely on individual motivation and rather than on any kind of systematic or institutional practice to move patients through referrals and other challenges of navigating their health care. So before closing, I just wanted to offer a reminder about why this topic is so important. A report was released by the Institute of Medicine just last week, and it highlights the stark disparities in life expectancy for 50-year-olds based on their income status. So this graph illustrates how the life expectancy gap has widened for 50-year-old men in the 30-year period between 1980 and 2010, with the wealthiest men making the greatest gains, while life expectancy for the poorest men has remained flat. And this means that on average in 2010, the upper income man was expected to live until 89 years of age, while the man with the lowest income would on average live to only 76. For women, the gap is even wider, with the wealthiest of women on average living to 92 and the poorest to only 78 years of age. And these data suggest an actual decline in life expectancy for the poorest women. And this is a staggering difference in life years of more than 13 between the wealthiest and the poorest women. Now, of course, there are many, many factors that contribute to life expectancy, and getting people the preventive health care they need, however, provides sort of one concrete action that can be taken to reduce these disparities and, irrespective of socioeconomic status, ameliorate this kind of trend. So in conclusion, we hope that the lessons that we learned from this HAPPY project will be useful for the community health centers, for community leaders, aging services providers, public health agencies, and policymakers, and that these collaborative efforts can contribute to increasing the use of clinical preventive services and improving the health and aging of older adults in South Los Angeles. So thank you so much, and we'll take any questions you may have.
Okay, are there any questions from the in-person?
Yinging.
That is a really very important project. One question is that some of the community members may not be FQC patients.
Mm-hmm.
And so your referral and the connection, how things
That's a really good question, something that we're still grappling with, I think. So the question was whether that some of the community members and organizations, the people that frequent those community organizations may not be patients at the community health center that's part of our project. So our approach to this is really to start with this coalition of community health centers, but with the idea that this is really building a framework, ideally that we would expand out, that this would become a more, inclusive effort, really as a collaboration across the region. I think that the other piece of that is that the community organizations may also have people that don't have a primary source of health care. So there's an opportunity to reach people that aren't getting primary care. We don't know going in really which, where those patients fall in their affiliation with those community organizations. But I think this is our starting point. We have to begin with a concrete set of clinics and health centers, and community-based organizations will learn more as we extend out. I think that the evidence-based educational programs can direct people to any primary source, so they can go to their own primary source of care. And so that's, another piece. I don't know if you wanted to add anything to that.
No, I don't think I have much more.
Okay.
I would agree.
Okay, I've got an online question. Besides health screenings and vaccinations, were referrals made to any preventive program or management programs, such as the chronic disease self-management program from Stanford? If you could repeat that question.
Okay. Let me see if I got that right. Is it right here in front of me? No.
No, it's
So besides the referrals?
Besides health screenings and vaccinations,
yeah.
were referrals made to any preventive programs or management programs, such as the chronic disease self-management program?
You mean so if I understand the question, in addition to referrals for clinical preventive services that we're talking about here, were there referrals, is that part of our project?
Besides giving the actual services, health screenings, vaccinations.
Besides giving the services, would we refer to chronic disease self-management
I can
programs?
take this one, I guess. So I think it's, from the beginning, we started out, and I mentioned earlier, there's so many evidence-based effective services. There's so many evidence-based effective services that are out there, and people may have heard of the chronic disease self-management program that Kate Lorig initiated and is promoted at Stanford, which we know works, but we had to have a little bit of a narrow window. I think we've fixed on the ones that, essentially the ones that were mandated by the funding agency. So our hope is that it may be that if people really want to refer to something like that, as long as you combine it with something such as breast cancer screening or colon cancer screening, we'll support that. But there are other, good ones, bone density screening and smoking cessation counseling and fall prevention. But we just felt we couldn't do everything for everybody, so we had to start with a relatively small but important set of CPS.
And just to add to that, I think that with the chronic disease self-management programs, for those community organizations that are involved in that and providing that, this really is a natural segue. Those who are providing the self-management programs would make a good partner for these preventive services, because it's really just another level of management. We're a little bit more upstream before people get to that stage where they need that.
Yes, we're hoping to prevent the chronic disease.
That's what we're hoping to do.
That's the hope.
Okay, any questions from the in-person folks in the room?
Dave?
I noticed you had one of your early slides on payers, and you differentiated HMOs versus fee-for-service, and I'm just wondering, the tradition of HMOs kind of being more focused on preventive medicine, if you pick up any of that in the clinical work that you do.
Okay, so the question, I have to remember, I have to repeat the question. The question is the differentiation between the Medi-Cal HMOs and the fee-for-service, and whether we've heard about any differences in those groups. We're a little early on with our analysis of the clinic utilization data, but we certainly, on a broad stroke answer, I can say that we're seeing some differences in utilization rates, if that's sort of where your question's coming from. And I don't want to say this as a finding because this is very preliminary, but it seems that the managed care, and Rosanna can substantiate this for me, the rates of utilization were a little bit higher on average through the managed care HMO, through the managed care Medi-Cal. But this is very, very preliminary, just as like one clinic that we've looked at, so. Stay tuned.
One other point to make is, I think it's interesting looking at someone who's practiced for over a decade now. So the HMOs really led the forefront to provide free preventive services. They have the incentive, right? They have comprehensive care, and they would give free mammograms, free colon cancer screens. Now with the ACA, pretty much everyone, these people that we're talking about, are getting free service. So that barrier is cut out. But it's just a challenge of getting people to A, know that they need it, and B, figure out where to get it and all that. That really is where we're digging in to make a difference. But I agree there may be some differences we're seeing by insurance type, but I think the larger picture is one of if it's there, if you build it, will they come? And we're building it, but we just have to get them to come. So.
Okay, we have another online question. Oops, it's just got away from me. Okay. They're wondering if there's a role for retail clinics, CVS, Minute Clinic, Target clinics, etc. Are these present in South LA? Do community health clinics work with them? Has UCLA thought about them as an asset? It seems like a good opportunity to give people convenient access.
So the question is about whether we've looked at or considered including or working with our community health centers to include retail clinics, CVS Minute clinics, and so forth. I think it's a really good question. It's not, we haven't looked specifically at that entity. We have mapped the CVS pharmacies, and of course many of them do have the Minute clinics. So it's not certainly without, it's not, we wouldn't exclude working with those clinics if there was a way that they could work with the community health centers that are part of the coalition.
I will say though that, and I have to admit I'm a little biased being in a traditional health setting, but my belief in Minute clinics is if you have a sprained ankle or you have a fever or any of those things that basically an ER would take a long time, Minute clinics are better and more efficient. But the issue is not just the screening, it's the follow-up, right? So you get the mammogram, then you get the lump, and that's really the whole point. Then what do you do then with the abnormal mammogram, and are you plugged in to refer? And I'm just not sure that Minute clinics are set up to deal with abnormal screening tests, and if you don't do that, you don't even want to screen in the first place because it just leads to anxiety and problems. So I'm a little bit hesitant, but certainly as a group we're open to discussing any options. But for the ones that really, the great majority of the ones that we're talking about, the whole key in my mind is what do you do when it comes back abnormal? And unless we know the Minute clinics are well set up to do that, or we can set up a thing where we would then transfer to another clinic that is set up to do that, just makes me a little bit wary.
Anyone from the room have a question? Any questions from the room? And I'm going to conclude with the two online questions that we have. One is this cohort of FQHCs on a similar database for documentation of services, or is this beyond the scope of the project?
Okay, so are they on the same, are the cohort of clinics on the same database? Actually, we're fortunate 7 of the 8 share the same population health management database. Which is going to make it hopefully easier for us to do comparison across and collect data consistently across the clinics, the centers. And one is on a different system. So that does pose some challenges. I think that we really, have to work with the health centers with the data they have. But we're inspired that we do have consistency, in theory, with 7 of the 8. Yeah.
Sounds good.
Okay. And last question, is there enough capacity to bridge the gap in these communities, or will the clinics have to significantly scale up?
So the question is, is there enough capacity to bridge the gap between the clinics and the community, or would the clinics have to scale up in order to bridge that gap? I think that it's really a two-way street. I see this as participation on both sides. Community organizations first need to see that they have a role in this, that they can be a player in this. And the community health centers, they're, of course, this is closer to their core mission. They provide these services. So they may be more motivated and more incentivized to actually work on increasing utilization. So maybe it's a little bit of a heavier lift for the community organizations, but I think it can be achieved. I think that the partnership piece will require some nurturing, to develop those partnerships and the collaboration across community organizations and health centers.
So that's a really interesting question, I think. So people saw the map with the 40 clinical sites for these 8 CHCs, and a lot of those are fairly new. So I don't fully understand the details, but I think there's economic incentives in place now to expand, which makes it more attractive than it was. So we have a lot of clinics opening sites. In addition, now people are more insured, and then actually they can even go elsewhere. So I think, capacity is always a limitation because, as Kathryn mentioned, the workforce is changing. It's hard to get the doctors there, but the infrastructure is there. I just worry about the specialist care because I think the GI doctors to do colonoscopies, the radiologists to read mammograms isn't really expanding. And there's been a real problem with getting specialty care, particularly for people with no insurance or with Medi-Cal. And so I think that may be an issue that we have to face with. I think there will be enough primary care settings to get folks in, but again, you have to pay attention to the whole continuum of this. And I think that is something that we in the clinics are going to have to struggle with together, and the community-based organizations.
Okay, well, that's it. Thank you very much. We can round the process.